Alright, so time to finish up NBME 18. Not so bad of an NBME. There was quite a mixture of questions here, but I did find all the questions to be pretty easy. I think I got 6 wrong overall from the 200 questions, but I will have to say that I didn't do the whole 200 questions back to back, right? So I didn't sit and do all 200 questions in like the standard time that you have for an NBME. So my brain wasn't burning out or stressed in any way. So that's definitely going to play a big role in the fact that I was able to see what's happening in every question for the most part. Even the ones I did get wrong, they were not. They were really not that bad. So even those were not questions that I know everyone's going to get wrong or something like that. So yeah, just gotta make sure that you are practicing question taking so that before your actual test comes up, you practice taking long spans of non-stop questions so that you don't burn out when you're on your real test and are able to think concisely and clearly, which is something you really build up to from just doing a lot of practice. Alright, so let's wrap up NBME 18. We left off over here the last 25 questions. So 176. The prevalence of high-grade cervical epithelial neoplasia in an unscreened population is as high as 5%. The prevalence in a population with a history of negative pap smear results is as high as 0.2%. Right? So people who had a negative pap smear didn't really get cancer or were safe of cancer, or you're not going to get cancer because you got a negative pap smear. Basically, people who were keeping up with their regular tests didn't end up having cancer, which is great. So as the prevalence decreases, which of the following will decrease? So at the end of the day, none of that really meant anything. The question is just a question on its own without any scenario. When prevalence decreases, what other things decrease? So this isn't something complex where you have to know extreme definitions or anything. Prevalence is basically how many people have the disease at the given time, right? A lot of people have the disease or no one has the disease. Now, when prevalence decreases, that means that fewer people around you have the disease, right? So if everyone has the disease or no one has the disease, that affects your test result value, okay? Looking at your answer choices, sensitivity and specificity, those are intrinsic, right? Those are inherent to the test, not the disease, right? So sensitivity and specificity are values that really tell you more about how good a test is, not so much about how many people have a disease or something like that. And false positive rate, as choice A, that's just another way to talk about specificity. Okay, it's related to specificity. So those don't change with prevalence or anything really. But if everyone has a disease, if everyone has a certain disease in a given population, then the positive predictive value will increase. And if no one has it, then the positive predictive value will decrease and the negative predictive value will increase. Basically, if everyone around you has some major disease, let's just say AIDS, for example, right? So if everyone in your city has AIDS and you come in for a test and your test result is negative, that negative predictive value is very little, right? You'd be surprised. You'd be like, whoa, negative. Everyone here has AIDS. How do you not have AIDS? So negative predictive value would be really low if prevalence is high, right? That's the opposite of this question where prevalence is low, so positive predictive value, right, will decrease. Okay, if prevalence is very low, positive predictive value decreases, and that's going to be your answer choice C. Predictive value of a positive test result is the one that will decrease because they asked you what's going to decrease. All right, predictive value of a negative test result will go up if prevalence is low. Next question, a 68-year-old man is brought to the emergency department because of a 3-day history of increasingly severe deep chest pain. He also has had shortness of breath, stridor, hoarseness, difficulty swallowing, and a non-productive cough. He has a long-standing history of hypertension. He smoked 2 packs of cigarettes daily for 45 years. Temperature is 99 F, pulse is 80, respirations are 15, and blood pressure is 160/94. The lungs are cleared auscultation. Physical exam shows a visible pulsation above the manubrium of the sternum and displacement of the trachea to the right. Our murmur is heard in the second right intercostal space. Which of the following is the most likely diagnosis? So the answer choice here that was a bait was pneumothorax. They wanted people to pick pneumothorax because you see the tracheal displacement, and if you're still studying and you haven't really managed to master what tracheal deviation tells you, then you would not be too sure. But generally speaking, this is just a patient with an aortic aneurysm. He's an old man, right, with deep chest pain and long-standing history of hypertension and smoking, both things. Now, smoking leads to aortic aneurysm. In what is the first A? Aortic aneurysm. I forget what the first A was right now, but abdominal. Sorry, abdominal aortic aneurysm. Right, triple A in an adult. Okay, abdominal aortic aneurysm due to atherosclerosis and smoking. So there's a bunch of A's: atherosclerosis, adult, mostly really old adult, and abdominal aortic aneurysm. So that's all related to smoking in these patients, and it's the abdominal one because there's no vasovasorum there, right? So basically down here, what happens here is that let's say, for example, I'm going to draw something. So let's say, for example, you have like atherosclerosis. Let's change the color for this. So let's say you have atherosclerosis like of that much of the artery, right? So now that portion cannot really get blood supply, right? You can't really give blood supply to that portion of your aortic wall, and there's no vasovasorum, so there's no blood coming from inside either. There's really no way to get any blood supply there, and then you get this kind of aneurysm, okay? And if you have a thoracic aortic aneurysm, that's usually due to actual invasion of the thoracic aorta, often because of syphilis. You would see that with syphilis. You could also just see it in Marfan's, right, because of myxomatous change. That's going to be a thoracic aortic aneurysm due to cystic degeneration, right, or tertiary syphilis. Either way, you can have something called an ankle brachial index because blood supply to your brachial stuff is going to be fine from the upper part, but descending aorta is what gets messed up in these cases, right? In aortic aneurysm, descending aorta gets messed up, so your ankle will not be getting the same pulsations and amount of blood as you will have in your brachial area. So those are the things related to smoking. Hypertension causes aortic dissection, where you get a false lumen that can then later become a tamponade, right? So you get a dissection here in the ascending part or the latter part, and depending on where the dissection is, the ascending one can actually end up covering up the whole heart, dissecting the whole skin off the heart, and you get tamponade, or just keep going down this way, and that's going to be really bad too. This is not aortic dissection. They didn't even put it as an answer choice. But this is aortic aneurysm. Now, what does the tracheal deviation part tell you? Well, pneumothorax is discussed on page 754. This was a trick question baited by the tracheal displacement, or trick answer choice more so. The question states right displacement of the trachea and a murmur in the right second intercostal space. The murmur is related to the fact that, whatever's happening has somehow moved the heart over a little bit or something like that. But if you have tracheal displacement, right? They tell you that the displacement was to the right, so the trachea moved to the right. The only time it moves away from something is you run away from tension. So in a tension pneumothorax, the trachea deviates in one direction, and the opposite side lung is just full of air, right? Crazy tension, hyperresonant tension pneumothorax. In the other ones, it moves towards it, but then you wouldn't really have any sounds there, right? Second intercostal space, they actually hear a murmur. That's not going to happen. This was not a pneumothorax patient. In addition, they would have told you, that the patient has difficulty breathing. But here, there's really just shortness of breath, hoarseness, difficulty swallowing, and non-productive cough. Not difficulty breathing. In pneumothorax, you can't really breathe, so this would have to be there. Difficulty breathing would be a big part of the question, and he would be in extreme distress. And that was, there was no reason to pick that as an answer choice, right? And the other answer choices really don't make any sense. 178, a 28-year-old man is undergoing evaluation for infertility. He is a weightlifter and takes anabolic steroids. Which of the following mechanisms best explains his infertility? And they made this so easy because they put the answer choice suppression and gonadotropins, and that was really it. It's not impaired liver metabolism or any of the other things that are there. It's just suppression of gonadotropins. Steroid abuse leads to excess testosterone, which inhibits the hypothalamic pituitary gonadal axis, decreasing intratesticular testosterone. Remember that in your testes you have proteins that, basically testosterone binding globulin that retains testosterone in the testicular area. which helps you develop more sperm. If you decrease intratesticular testosterone because you're not making it there anymore, you end up getting azoospermia and even testicular atrophy. Right? Women who abuse steroids get virilization, like hirsutism and stuff like that. Right? So that was really easy. Page 693 actually discusses this topic in reproductive. Right? They directly talk about under androgens, androgenic steroid abuse. Right? So abuse of anabolic steroids, hypothalamic pituitary gonadal axis inhibition. So now you stop making testosterone and you run out of intratesticular testosterone, which causes testicular atrophy and azoospermia. Women will get hirsutism, acne, breast atrophy, male pattern baldness, stuff like that. Hirsutism. Realization. 179. A 48-year-old man is referred for evaluation of possible hypertension. Based on 20 measurements, the patient's average diastolic blood pressure is 94, and the standard deviation is plus or minus 8. If only 4 measurements were made rather than 20, which of the following statements would best describe the width of the 95% confidence interval with regard to the mean blood pressure? Okay, so now this question I did have to read like 3 times just to make sure I was really grasping it correctly. But then I told myself, all right, listen, they were doing 20 measurements before, right? That's kind of like having 20, like sample size, right? 20 people. Now they cut down to 4 measurements, which is like a smaller sample size, like having 4 people in your experiment. If you have a smaller sample size, that's going to be bad, right? You run out of power. Everything's going to just, the data is not going to be that significant, which is analogous to saying that your 5% thing will be more than 5%, right? P is going to be much more than 0.05. So you look at your answer choices, they're asking you what's going to happen to the 95% confidence interval. Is it going to be smaller, larger, the same, or changed, right? For the mean, the 95% confidence interval should not include 0, since mean is division and you cannot divide by 0. That's just a memorization aspect. Here, they will be reducing the sample size, which reduces power and increases the chance of type 2 error. So the width will be worse, aka larger. It's like saying, I think 1 plus 1 equals 2 plus or minus 100. Well, duh. Oh, I think I put the wrong thing here too. Let me just make sure. It is larger, but I don't know why I put A. Where's the thing? Yeah, it's just larger. Oh yeah, here you go. Yeah, larger is the correct answer. Where's B? Right, not smaller, because this example right here, this is literally what I thought of when I was doing this question, right? So if you ask anyone a math question like, hey man, what do you think 500 times 300 is, and you can do that because you do 5 times 3, you're done. But something really weird, if you ask someone that and they tell you, oh, I think it's something like, and this exact example is pretty good. If you just ask someone, what do you think 1 plus 1 is, and they say it's probably 2 plus or minus 100, well, they definitely can't get that wrong now, right? Because it fits the correct answer choice. So that's kind of what happened with this patient scenario here, right? So this 48-year-old man, the test that he signed up for, the more measurements you get, right? Basically, it's like saying we're calculating an average. So if you only do 4 measurements, maybe 2 of them were like around 90 and the other 2 were like 130, that's a big width. But if you did 20 measurements and he had a bunch of measurements that were around 120, then the average gets closer to 120, right? You make the average smaller. The more measurements you have, the average becomes more and more and more concise, right? That's the way you want to be able to approach stuff like this. Now, obviously, you won't have that much time to think of all of these scenarios that I just discussed right now, but generally speaking, you should be able to deduce the fact that fewer measurements was like having a smaller sample size, right? With a smaller sample size, your mean, right, confidence interval will be larger. Okay, larger confidence interval. And it's going to be such a large confidence interval, it won't really be significant anymore. Okay, so now on page 270, they talk about the actual breakdown of stuff like that. So type 1 error, type 2 error, right? What the correct result is all about. Before that, here they discussed the null and alternate hypothesis and what they're supposed to mean. And you need to understand all of that very well, master it, not exactly memorize it, but truly understand it like a biostatistician. And then 95% confidence interval for the mean difference between 2 variables includes 0. If it includes 0, then it's not significant. Okay, so it should not include 0. Similarly, 95% confidence interval for an odds ratio or relative risk, right, includes 1, That's also not good. Okay, so you don't want the 95% confidence interval for an OR or RR to have 1, and the 95% confidence interval for a mean difference to have 0. Okay, you do not want those things there. If they do, then you understand that whatever happened was not significant, and then you do not reject the null hypothesis. Remember, you never say you accept the null hypothesis. That's not correct terminology. Never say that you accepted the null hypothesis. You just couldn't reject the null hypothesis. The null hypothesis is the hypothesis of no difference. Okay, so that means that your experiment pretty much failed. You just wasted a lot of money trying to prove something that was not so true at all. Right? So spend a little bit of time in this stuff whatever day you decide to do biostatistics, and really be able to talk about it without the book in front of you. This was a straightforward question. An 8-year-old boy suspended from school because of persistent disruptive behavior. Teacher explains that he's in constant motion, never completes his assignments, been treated in the emergency department several times because of skateboarding injuries. Drug therapy is indicated. What is the most appropriate? So now, this guy doesn't have any other issue besides ADHD. He's not doing anything bad. He's not punching people. He's not burning anything. He's not standing up to any opposition against authorities, right? None of that. He just has ADHD. Constant motion, doesn't focus, probably just super hyperactive. This is why he's getting injuries. So the treatment for that was just methylphenidate, okay? Stimulants. In fact, all those childhood disorders, all those childhood and early onset disorders in psychiatry were treated with, generally speaking, stimulants. So let's take a look at that real quick. We just did that recently, right? Because I'm still in the psychiatry section. I'm going to continue that on from tomorrow at noon. So right here, ADHD, right? And they tell you treatment stimulants like methylphenidate, or alternatives include atomoxetine, guanfacine, and clonidine, which I talk about right here, alpha-2 agonists and stuff like that. But that's really it. And if you look at the other ones, right, so you can see the rest of them have like CBT as a mainstay of treatment, which is not that bad to remember. This question said drug therapy was indicated, so CBT was not an answer choice. Otherwise, CBT can also be an answer choice for this too, right? Behavioral therapy. Where else was it? Tourette. Tourette has a bunch of things for treatment, so make sure you understand that one. And that's really all there was for this, right? Specific learning disorder, again, that encompasses many different things. So stimulants, though. The other answer choices didn't really make any sense. They're just not related to this, right? 181, a 44-year-old pregravid woman at 15 weeks gestation comes to the physician for a routine prenatal exam. The physical exam shows the uterus consistent in size with gestational age. Amniocentesis shows a markedly increased alpha-fetoprotein concentration. This patient's fetus is at greatest risk for which of the following defects. A lot of people got this wrong. Okay, a lot of people fell for some kind of thing that first aid kind of didn't really make so clear, I guess. In first aid, they tell you that AFP is elevated in many things, but not in spina bifida occulta. Right, so let's take a look at that. 533. Right, so neurotube defects. They tell you that AFP in amniotic fluid will be high, and in maternal serum as well, except in spina bifida occulta, where you're going to have normal AFP. Right, so spina bifida occulta is this one right here, where you have the tuft of hair, right, but nothing came out. What you need to understand, though, is that all three of these scenarios are spina bifidas. They're just not called that. All of these are spina bifida. So meningocele and myelomeningocele, I wrote this recently after that question. All of these are spina bifida, but the occulta form is unique in the sense that it is hidden, so you will not see elevated AFP there, right? But meningocele and myelomeningocele are also spina bifidas, okay, and these two will have elevated AFP. You're also going to see increased acetylcholinesterase in amniotic fluid for confirmation. So the only answer choice worth picking really was spina bifida. The other ones you should know are irrelevant. They're unrelated to AFP elevation. Horseshoe kidney is just a development defect of the kidney. Congenital heart defects, no. Malrotation of the gut, no. And hypergonadism isn't really a congenital thing per se. Okay, so that was really it for that question. Kind of messed up, but that's not really their fault. It's first aid's fault for kind of explaining it wrong. This question was kind of stupid. This one was really dumb, but I got, again, like, it's all about knowing your topics really, really well. I got lucky, but I was very close to picking the wrong answer here. 72-year-old woman comes to the physician because of a 6-month history of increased bruising on her forearms. She appears alert and well-nourished. Physical exam shows extensive wrinkling, scaly erythematous patches on the face, and irregularly shaped brown macules on the face and forearms. There are ecchymoses in various stages of healing on both forearms. The ecchymoses are more numerous on the right side for some reason. Okay. Lab studies, including a CBC and coagulation studies, are normal. So that's a big deal. And then she has noticed no bleeding from her gums after brushing her teeth. Which of the following is the most likely cause of the ecchymoses in this patient? So the bait answer choice is C, which I was very quick to think of, but then I realized, like, no, they said everything's fine. More importantly, the fact that she doesn't have bleeding from gums after brushing was where you can knock out impaired platelet function. Okay? In fact, they spent a good amount of time in this question pointing out the fact that she has, extensive wrinkling, right? That, and brown macules on the face and forearms, right? Ecchymoses everywhere, but more on the right side. The fact that the ecchymoses are more on the right side than the left is a sign of the fact that it's not systemic, right? Because it's asymmetric. That's a big deal right there. So you look at your answer choices. This is not exocytosis of lymphocytes, nor is it ultraviolet destruction of Langerhans cells. Those two answer choices were just stupid. They didn't really make any sense. So I just went with B. I felt like this was something NBME is just trying to teach you like an idiot. And that's exactly what it ended up being. This is also called actinic elastosis or solar elastosis. It's an accumulation of abnormal elastin in the dermis of the skin or in the conjunctiva of the eye, which occurs as a result of the cumulative effects of prolonged and excessive sun exposure, a process known as photoaging. This is basically why they described so much about her skin, and you can cancel C once they said that there was no gum bleeding and normal coagulation labs. Okay, so coagulation studies and CBC. The CBC includes platelets, and everything's fine. All right, 183. A 24-year-old woman is brought to the emergency department after taking an overdose of drug X. There is no specific treatment for this type of overdose, but it is known that drug X follows first-order kinetics. And a lot of people freak out at this point if they don't really know what that's supposed to mean. So you should look it up and know what that means. Zero-order kinetics includes the P guys, PEA, phenytoin, ethanol, and aspirin. This is first-order kinetics where everything goes with half-life. Lab studies show a serum concentration of 32. Okay, and then 6 hours later it becomes 16. So they just gave you the half-life. 32 became 16 in 6 hours. Current guidelines indicate that the patient should not be moved from the ICU until the serum concentration is 1.1 at least. Which of the following represents the minimum number of hours she needs to stay in the ICU? So you just keep doing halves, right? In 6 hours it became 16. In 12 hours it'll become 8. In 18 hours it'll become 4. All right, you just keep adding 6 hours and keep having the concentration. So 24 hours it'll become 2. And then in 30 hours the concentration will be 1, which is less than 1.1. So after 30 hours, she can go home. Or she can at least leave the ICU. Not go home, but leave the ICU. And that was it. 184. At autopsy, the heart of a 76-year-old woman shows concentric enlargement of the left ventricle. Microscopic examination of the heart shows enlarged myocardial cells with large nuclei. Which of the following diseases was the most likely cause of the cardiac enlargement? The most likely cause. Now, the bait of an answer choice is C, hypertrophic cardiomyopathy, where you know you're going to see concentric hypertrophy, and you're going to see the same kind of findings that you're seeing in this patient. But the most likely was B. Right, so this topic is very, very big. A lot of people don't quite understand it very well, and a lot of people misunderstand it. So it's very important to understand what's actually happening here. Okay. Hypertrophic obstructive cardiomyopathy. Right? You're going to see marked ventricular concentric hypertrophy where the sarcomeres are added in parallel, so you get tiny ventricles. Okay, this patient they described. What did they describe? Enlarged myocardial cells, right? Concentric enlargement, right? Concentric enlargement of the left ventricle. They described that as concentric hypertrophy. Concentric hypertrophy is seen in many things. The one that this book is talking about mainly is hypertrophic obstructive cardiomyopathy. That's a whole other thing. That's a disease on its own. right? HOCM, hypertrophic obstructive cardiomyopathy. It's autosomal dominant. It's due to the beta myosin and protein C, right? All of that, and it's what causes young athletes to die. Okay, so physiology: asymmetric septal hypertrophy, systolic anterior motion of the mitral valve, outflow obstruction, dyspnea, syncope, eventual death. Okay, that's one thing. But hypertrophic cardiomyopathy isn't always HOCM. Hypertrophic cardiomyopathy can also just be concentric left ventricular hypertrophy. Right? Concentric left ventricular hypertrophy is due to chronic hypertension or Friedreich ataxia. Really important to not skip these last two lines right here. Right? Our patient has concentric left ventricular hypertrophy, which is probably due to chronic hypertension in her, because you know she doesn't have Friedreich ataxia. HOCM would have been a whole different thing in a younger male or female patient with issues with, syncope during exercise. Very important to understand that difference. Even UWorld has a question where they give you an image like this, right? And look, you see the question right here: 54-year-old man, constantly ED, severe shortness of breath, palpitation, pulse oximetry is 83%, right? Crackles in the lung, chest X-rays consistent with pulmonary edema, which basically is a result of heart failure. Things are backing up from the heart into the lung again. ECG shows atrial fibrillation, rapid ventricular response. He dies despite appropriate care. Autopsy shows whatever you see right here in this big blue image. Histologic exam reveals myocardial fibers with large hyperchromatic nuclei, just like our question in NBME, right? Big nuclei. And mild interstitial fibrosis. What is the most likely diagnosis? The correct answer was hypertensive heart disease. This 54-year-old man did not have hypertrophic obstructive cardiomyopathy. That's something that's going to be symptomatic much earlier. This 54-year-old man had hypertension, which caused hypertensive heart disease, and that's going to be seen with concentric hypertrophy. The muscle got real buff to be able to fight against the hypertension, but in becoming so buff, the ventricle size became really tiny, so you can't really have much of a stroke volume anymore. That leads to heart failure and pulmonary edema, and that's it. Okay, very important difference to master correctly. Don't get confused. So both answer choices will always be there. This was all hypertension. This patient's issue was because of hypertension. 185, an investigator conducts a meta-analysis of 3 genome-wide association studies of Crohn's disease. The studies encompass 3,200 cases of 4,800 controls, all of European descent. The initial studies identified 11 significant loci with odds ratio above 1.3 to 1.5. The combined meta-analysis identified an additional 21 loci with odds ratio of 1.1 to 1.3. It is estimated that the 32 loci, 11 plus 21, identified explain about 10% of the overall variance in disease risk, with 2 loci accounting for 2% of the variance. So 2 loci were 2% of it, the other 30 of them were 8% of it. In total, those 32 loci just talked about 10% of the variance in disease risk. Previous studies of twins indicated a 50% heritability rate for Crohn's disease. Which of the following best explains these study results? Now, this kind of question really fucks people up, right? Because you're just like, what did I just read? What's happening here, right? I had no clue what to put, and told myself I would put B and move on due to the 10% part, and that's really all you can do, and B was the correct answer here, right? But you really need to make sure that you're able to stay calm when you read such a question, break it down, organize it, make sense out of it. So they're trying to see, right, in these 3,200 cases and 4,800 controls, they're trying to see genetic associations of Crohn's disease, okay? They found a bunch of loci that were related to it, and when they did a summation, those 32 loci only talked about 10%, right? But when they did twin studies, 50% heritability was seen. So 40% is missing. You look at the answer choices. A, analyses of 1,000 cases or less are as informative as meta-analyses. I read that answer choice and I was like, what are they even saying? Does that, what does that mean? That answer choice did not make any sense. I wrote here that as the theory behind meta-analysis tells us that a bunch of well-done studies can be synthesized to provide more insight than a smaller study. Right? A small study, you would rather do a bunch of well-done studies than do one small study. Right? So analysis of 1,000 cases or less is not as informative as meta-analysis. Initially, when I read this, it was just like, no, that doesn't sound right at all. B, the identified loci account for a relatively small part of the variance. And I was like, yeah, that's exactly what they just told me, right? The identified explain only 10% of the overall variance. That sentence is literally, the answer is in the question itself. So B, I was very, fond of. I keep going. C, the majority of contributing loci have been identified. Now, as you know, that doesn't make sense because they only identified 32 loci and that was only 10% of the stuff. They're still missing 40% more information. So C was wrong. The majority of loci have major effects on disease appearance. This one I couldn't really tell. I wasn't too sure. I mean, we've only really found 10% of the loci, and we can't really tell how much they give. Right? There's a lot more missing, so D didn't look too right. 2 loci provide evidence for autosomal dominant inheritance of Crohn's disease. And I was like, that's bullshit, right? Because that's not how this works. This isn't supported by 2 loci, only accounting for 2% of the variation in risk. Doesn't make sense at all. So B was the answer, and B was correct, right? B is the only sound answer choice for a pretty simple reason. All these identified loci only explain 10% of the variation, but we have 50% heritability, so that comparison is pretty key. Either way, questions like this really piss people off, and people, depending on how worn out you are, whether this is question number 1 of 200 or question 198 of 200, you can really just get pissed when you read something like this. You got to be able to remain calm. 186 was very easy. 23-year-old G1P1 is brought to the physician because she has not felt well since the delivery of her son 2 weeks ago. She has had ongoing fatigue, inability to breastfeed, and episodic lightheadedness when the upright position during this period. Pregnancy was complicated by preeclampsia, hypertension, and resulted in an urgent cesarean delivery. Immediately after delivery, she required blood transfusions because of bleeding and transient hypotension. Right, so that's really bad. When you see something like that, you think Sheehan syndrome, which is something related to pregnancy and bleeding too much and not being able to give blood supply to the pituitary, which is already going to need more blood supply than normal during delivery because during pregnancy, your pituitary does get a little bigger. She was discharged from the hospital after she had stable hemoglobin concentration of 10.8, which is still pretty low. She appears lethargic. While she is sitting, her pulse is 80 and blood pressure is 100. While she's standing, pulse is 85, but blood pressure is even lower. Okay, so orthostatic hypotension. Physical exam shows no other abnormalities. Now her hemoglobin is 11.6, so she's not, anemia isn't her biggest issue. Which of the following sets of serum hormone concentrations is most likely? So all you needed to understand was that during delivery she had Sheehan syndrome because of the excessive postpartum or peripartum bleeding, and her pituitary is not working, so all those flat pig hormones are going to be low. They listed out a bunch of flat pig hormones here, so they're all going to be low. Okay, but aldosterone is not a flat pig hormone, right? So that one is not going to be low. Okay, but the other ones that are all flat pig, prolactin, ACTH, TSH, even FSH, LH, all these things, right? Everything that comes from her pituitary, anterior and posterior, those would all be low. Aldosterone is going to be high because she's going to have decreased renal perfusion, right? Decreased renal blood flow. Renin is going to be increased. So renin, aldosterone, angiotensin system, the whole thing is going to activate. Try to fix her blood pressure, but it's not really going to work too well. Okay, so that was all this question was about. Sheehan syndrome. There's another differential called pituitary apoplexy. So you should be able to differentiate between the two things. The apoplexy won't really have anything to do with delivery. Right? Pituitary apoplexy is sudden hemorrhage of the pituitary gland, often in the presence of an existing pituitary adenoma. Usually presents with sudden, severe onset headache, visual impairment because of the big pituitary, and features of hyperpituitarism. Right? Empty cell syndrome is something that occurs in obesity. Right? So they tell you idiopathic, common in obese women, associated with idiopathic intracranial hypertension. Our patient has Sheehan syndrome, and that's it. Right? So very important. This is actually an AMBOSS question about pituitary apoplexy. And what you'll realize is the question isn't really about delivery. So that's the clinical thing there. 187, 45-year-old woman with joint pain due to rheumatoid arthritis comes to the physician for a follow-up exam. Treatment with over-the-counter agents has been ineffective. The physician plans to initiate treatment with a disease-modifying anti-rheumatic drug. However, because of the delayed onset of action of these drugs, the physician also prescribes another agent to be used until the DMARD becomes effective. Which of the following additional agents was most likely prescribed? You look at all your answer choices and you see prednisone there, and you know prednisone starts working real quick. But if you never heard of the DMARDs, then that might have confused you a little. USMLE RX talked about them. So I actually have them in my notes. 512 right here. For rheumatoid arthritis, the disease-modifying anti-rheumatic drugs. Okay. See, disease-modifying agents, these guys, methotrexate, sulfasalazine, hydroxychloroquine, leflunomide, any of these. Those drugs reduce long-term joint destruction and take more than a month, more than 6 weeks, to actually, kick in and have effect. Short-term treatment with glucocorticoids or NSAIDs can provide rapid temporary relief before the DMARDs kick in. Glucocorticoids can be more effective than NSAIDs. Alright, so those are the key things. So if you had both things as answer choices here, you would pick the glucocorticoid, and that's prednisone. That's it. Alright, the other answer choices, no. Hydroxychloroquine is one of the DMARDs. Infliximab, no. Etanercept, no. And I don't even know what that first one is. Aranolin? Let's see what that is. Aranolin. Medication, yes. Is a gold salt that is capable of eliciting pharmacologic actions, can treat rheumatoid arthritis. It's probably one of the DMARDs also. Right? Suppress inflammation and stimulate cell-mediated immunity. Okay, so it is a medication. It's a gold compound, apparently. That's the drug class. Avoid alcohol. Alright. So yeah, prednisone just made the answer choice really easy. Plus, even if you don't have any idea what DMARDs are, the only thing was you needed to pick an answer choice of something that will give almost immediate relief in a patient with rheumatoid arthritis, and that's going to be prednisone. 188. A 22-year-old newly gravid woman comes to the physician for counseling prior to conception. Menses have occurred at irregular 26 to 32-day intervals since menarche at the age of 14 years. She's 5 feet 4 and weighs 85 kilograms, and BMI is super high. Her blood pressure is 130. Physical exam shows mild hirsutism and velvety brown thickened skin at the base of the neck around the axillae. So this patient is the clinical classic scenario of someone who probably has, what is that? Because she has the hirsutism, she's also obese, she has her irregular menses, so this is going to be, I didn't write it down, what is that thing? I'm forgetting the name of the disease. Man, that's so lame. No, right here. Maybe right here? No, before this, actually. Yeah, polycystic, there you go, PCOS, okay? So you can see she's going to have this kind of hirsutism thing happening, right? They also have unruptured follicles and cysts, so they have periods of anovulation and really messed up menstrual cycles, okay? So all of that combined, the clinical picture they painted for this patient was of PCOS, an obese patient with hirsutism and anovulatory cycles, right? Or irregular menstruation. Now, the correct answer was hyperinsulinemia, right? That was the correct answer here. They then go on to ask you, physical exam shows hirsutism, velvety brown skin, blah, blah. The patient most likely also has, which are the following conditions. And the velvety brown skin and all that they're describing is actually the acanthosis nigricans, okay? So acanthosis nigricans is something you can see in obesity, you can see in diabetes, and you can also see it as a sign for GI cancer with the lesser Charlotte sign. All right, so really important to watch out for that. The other answer choice is just completely irrelevant. Hypoandrogenism is actually an answer choice to bait you into it. But once you recognize this is PCOS, you immediately paint this clinical picture and know it's hyperinsulinemia. Okay, it's not going to be hypogonadism because her ovaries are working okay. She doesn't have issues releasing estrogen and all that stuff. All right, so many notes here. You see, I even have like an entire description of something called the progestin challenge test and many other things to really understand the whole pathophysiology of PCOS. So if you need to pause it and read this, then definitely go ahead and do so. And just make sure you really understand this because this is actually very common because obesity is very common, especially in America and Western nations in general. So yeah, don't miss out on that. Let me just put this page 2703. Okay. Okay, so that's it for that one. 189. 33-year-old woman comes to the physician for a follow-up exam. 3 weeks ago, she underwent oophorectomy because of epithelial ovarian cancer. At today's visit, the physician recommends adjuvant chemotherapy, including paclitaxel. Which of the following best describes the mechanism of action of paclitaxel in this patient? So remember, taxes stabilize society. Paclitaxel and the other taxanes, their job is to stabilize microtubules. Okay, so stabilization is the inhibition of disassembly. Microtubules disassemble very quickly. Paclitaxel stops that. The other answer choice that was debated was E, prevent microtubule polymerization. Right? It seems very plausible to pick that if you don't remember taxanes at all. But vincristine and vinblastine, those are the other class of drugs that worked with taxanes, similar kind of thing, because they both work at the M phase. The vinca alkaloids, those medications actually inhibit polymerization. That would be choice C. Okay, so that's under hem-onc, but this is the oncology stuff. So you want to make sure you can at least very well remember these guys, because they're the only ones that work in the M phase. Okay, vincristine, vinblastine, and then chemotoxman helps you remember the V's, right? So vincristine crisps the nerves, vinblastine blasts the bone marrow. Okay, peripheral neuritis, constipation, areflexia, vincristine, neurotoxicity. These medications are not that hard to remember, nor their side effects. But again, remembering something is like a memorization thing. It takes time. It takes a lot of time. You just have to keep revisiting it. This was an interesting question. As a 65-year-old man with cancer of the cecum of the colon, right? So colon cancer in the cecum is found to have a metastatic lesion in the right lobe of the liver. Which of the following is the most likely venous route of metastasis? And then you start looking at these, and none of them will make sense to you if you've never really studied the portal and GIT blood vessels. Right, 395. This is probably the most complex or most important and complex topic of GIT, which is actually the easiest chapter of first aid. Right, so these are your normal arteries. Right, see, this is your celiac trunk, and then you have your SMA and IMA. So these are the arterial supply. Not that bad at all. Then here, this is your portal supply. This is your entire portal blood supply. So you can see, right, that the intestines, right, you have your ileal, right, jejunal veins, ileal veins. Here in the cecum, right, this is the cecum over here. So in the cecum, this area is going to go to your ileocolic vein. Okay, ileocolic vein. Right colic and middle colic are right here. So those are for the ascending colon and the transverse colon. Right, middle colic drains transverse colon. Ascending colon drains into the right colic. Right, the intestines drain into the jejunal and ileal veins. The cecum drains into the ileocolic vein. Right, so all of those are important. These guys, all of these guys go into your superior mesenteric vein, which then goes directly to your hepatic portal vein. The descending colon and the rectal stuff, superior rectal vein, these guys go into the IMA, which you have to remember is actually branching off of the splenic vein. Okay, then they go into your hepatic portal vein. So this is just anatomy. This is anatomy. If you've never looked at it, you're not going to remember it, right? And before you even try remembering that, you really need to master your celiac artery, right? The celiac artery is very important, high yield with your liver issues, gastric ulceration, and stuff like that. So you really need to know these branches very well, be able to write them and reproduce them without the book in front of you. Also remember that it also supplies the pancreas. Okay, so there was a NBME question mentioning how the tail of the pancreas is actually supplied by the celiac vessels, right? The celiac right here, this stuff, your gastroepiploic, okay, and then some branches of the spleen, the splenic one, they also supply the pancreas. Your pancreas gets blood supply here, you see. So really important to memorize that stuff. That's one thing. Then this is probably the easiest stuff. The SMA and IMA is super easy. So now you have this. So the SMV is with your intestines and ascending colon. IMV is for the descending colon and rectum. Right. So here the answer was just A. Ileocolic vein goes to the superior mesenteric vein, which goes to the portal, and then the right branch of the portal, right hepatic branch. That's it. 191, an otherwise healthy 35-year-old man comes to the physician because of several episodes of dizziness and fainting during the past 2 months. So several episodes of dizziness and fainting. He's very young. The father and several paternal uncles died suddenly. Physical exam shows no abnormalities. Serum lipid studies are normal. Angiography shows no blockage. ECG shows prolonged QT, so you know that they just wasted your time. This is torsades, right? Long QT syndrome, sudden cardiac death. Decreased activity, which of the following is most likely cause, and the answer is just going to be the potassium channel. And they put 2. Inward activating or outward rectifying? And the answer was outward rectifying. If you've never seen the delayed outward rectifying potassium channel being discussed, then you probably haven't watched USMLE RX videos or pathology videos about the heart. But they talk about this, right? So the patient has prolonged QT that he most likely inherited from his family. Since there are no deafness issues, he most likely has Jervell and Lange-Nielsen syndrome. Right? Romano Ward is the one that has autosomal dominant inheritance and has deafness. The delayed rectifying potassium channel is critical for myocytes. Right. 192. This one I think I got wrong. So a study is conducted to compare the incidence of MI in patients undergoing 2 different types of angioplasty or an operative procedure to manage single vessel coronary artery disease. A total of 1,000 patients are enrolled. Through a chance process, 500 are assigned to undergo the operative procedure, 250 to undergo one type of angioplasty, and 250 to undergo a second type of angioplasty. All patients are followed for 3 years to determine the incidence of MI. What is the best way to describe the study design? So I was rushing, I guess, and I was really just not feeling like doing this. I would have put E, right? Because prospective cohort, because they mentioned about, following someone 3 years. But this was actually a very easy question. They randomly chose patients through a chance process and then tried out different procedures, 3 different types actually. Some people thought it is E because these patients were followed for 3 years. I was one of those people. But cohort, right? Prospective cohort compares 2 groups, one with exposure and one without, and this study is not designed like that at all. All right, this was just F. It's just a randomized clinical trial. That's all this was. Okay, so yeah, don't fall for that pit. Definitely not an ecological community intervention trial. Definitely not a case control because there isn't a case in the control. In fact, case control should have helped me understand that it's not cohort either, because case control, cohort, they're all similar kind of designs, just different mechanisms, different ways of picking the people you pick. But the concept is the same. You have 2 groups, one with and without exposure, something like that. Right, so yeah, that's about it. 193. This was cool. This is sort of a bullshit question, but I did pick the right answer. So 36-year-old woman comes to the physician because of a 2-week history of fatigue, bleeding, bone pain. Physical exam shows pallor, hepatosplenomegaly, ecchymotic lesions. Right, you look at her, hemoglobin is very low, platelet count's very low. Right, polymerase chain reaction test shows an mRNA corresponding to the retinoic acid receptor alpha PML leukemia fusion gene, resulting from a reciprocal translocation of 1517. So this is acute promyelocytic leukemia, which you can fix with vitamin A. Treatment with all trans retinoic acid is started. In response to retinoic acid therapy in this patient, the fusion protein will most likely attract which of the following proteins to form a pre-transcriptional complex, right? They didn't stop the question at just that. They could have just written, it'll attract which of the following proteins. But they wanted the protein to do a specific thing. It's going to form a pre-transcriptional complex, which means that we're going to be doing transcription. So since you're going to be doing transcription, you need to be able to access the DNA, and the only one that allows you to do that is histone acetylase. The other answer choices are very irrelevant. Nitric oxide is extremely irrelevant. Protein kinase A is extremely irrelevant. So you're really just left with the histone answer choices, and we need to do transcription. They gave you that, pre-transcriptional. Right, the question says pre-transcriptional, so that means DNA has to be unwound, so acetylation will be needed. Right, ATRA causes APL cells to differentiate into their final form and stops them from proliferating, thereby ending the leukemia. 194. This was a really good question too. 35-year-old woman has congestive cardiomyopathy and pitting edema. Her urea nitrogen is 25 and creatinine is 1.8. Furosemide is started, and 5 days later, now you see this. So you look at the lab, sodium's low, bicarb 30, urea nitrogen is now 85, and creatinine is 2.2. Furthermore, they then tell you the urinary fractional excretion of sodium is less than 1%, which is a giveaway for pre-renal azotemia. And that's why this has J answer choices. It's either you know it or you have no idea what's happening, and then you're going to just randomly or to your best knowledge make an educated guess. But this is just pre-renal azotemia. Look, her fractional excretion of sodium is less than 1%. Her BUN is super high. So what's happening? Her BUN to creatinine ratio is very high because she must have low renal blood flow, so her kidney is retaining sodium and urea to conserve volume, right? This is pre-renal because the issue is before the kidney. Blood supply into the kidney for some reason became very low. Okay, she has kidney failure now. Alright, so that's really all it was. So you just pick pre-renal azotemia and you move on. Alright, post-renal azotemia is different. And then let's take a look at it real quick. So this is page 656. Right, acute kidney injury. Right, because of abrupt decline in renal function. Renal function measured by creatinine, BUN, and then how much they're urinating, oliguria or anuria. Our patient has pre-renal azotemia, decreased renal blood flow because of some kind of hypotension, maybe because the furosemide she started. Now, water, sodium, and urea will be retained by the kidney to attempt to conserve volume, right? So now you're going to have a super high BUN, okay, and then very low fractional excretion of sodium. You're going to retain sodium to retain volume. Intrinsic renal failure is different. In intrinsic renal failure, you can't retain anything, right? So fractional excretion of sodium is high, and BUN is also very low. You lose the urea, your creatinine is going to be bad to begin with, and then fractional excretion of sodium is going to be very high. You're going to lose all your sodium too. And you know something called epithelial or granular casts, okay? Post-renal azotemia is after the kidney, so now you're at the ureters and stuff. So this is due to outflow obstruction because of stones, BPH, any kind of cancer in that area, and develops only with bilateral obstruction or in a solitary kidney. Right? This is pretty rare to see. So not that bad. 195, 42-year-old man comes to physician for cast removal. When he was traveling in another state 6 weeks ago, he sustained a fracture of the left humerus that required open reduction, internal fixation, and cast immobilization. After removal of the cast, examination of the left upper extremity shows a well-healing surgical incision over the arm with no bone deformities. Just a waste of your information, waste of knowledge right there. Muscle strength is 2 out of 5 with extension of the elbow and 1/5 with extension of the wrist and finger. So basically he's unable to extend. And from basic anatomy, you know that flexing is musculocutaneous, extension is radial. Right? So you look at your answer choices, and they asked you, this patient most likely sustained a fracture at which of the following sites of the humerus? Radial groove had to be the answer. You see the image I put here from teachmeanatomy.com. The radial groove is one of the places where you can find the radial nerve and even injure it. All right, let's take a look at a little bit more. So page 482. Right, so upper extremity nerves, page 440, radial nerve. Right, so wrist drop, loss of elbow, wrist and fingers, decreased grip strength, loss of sensation over the posterior arm and forearm, and dorsal hand. Okay, so this is all related to like extension stuff, all the muscles that are gone. And let's take a look at some pictures. So that's on 489. So in my first aid, I put a bunch of pictures from various resources. Right, these are the UWorld pictures. So you can see right here. This is the other case scenario where you can have radial nerve injury, right? If you have anteromedial humeral fracture, medial median, right? Median nerve gets injured, so you're going to see symptoms of that. Anterolateral humeral fracture injures the radial nerve. Right? A lot of people always mess this up and think anterolateral is going to be ulnar nerve, but the ulnar nerve doesn't travel like that, right? The ulnar nerve, you can see right here, the ulnar nerve goes like kind of behind that and really avoids any chances of getting injured. Okay, very important to look at as many pictures as you possibly can. I have all these Netter's pictures in my book too, so you can see how the various nerves and muscles kind of go. Netter's has the best pictures. This is again showing you the same thing in the radial groove right here. Right, the breakdown of innervation. So very important to study anatomy with other resources because first aid doesn't really teach it that well. 196 was just a question to catch people off guard. During a study of regulation of cholesterol biosynthesis, a transcription factor that activates expression of HMG-CoA reductase is identified. So they identified a transcription factor. You should stop and you tell yourself that and then move on. Don't keep reading, because this is already, you can tell by looking at the picture that your brain is already probably pretty annoyed by this question. So make sure you understand each thing so you don't have to repeat yourself. So when you read the first sentence, understand that they identified a transcription factor. This transcription factor is initially synthesized as a large precursor protein with two membrane-spanning domains. Okay. The transcriptional activation domain is released by proteolysis when the membrane has a decreased cholesterol concentration, right? Because HMG-CoA reductase is related to cholesterol. The precursor protein is most likely initially produced in which of the following labeled areas? So now you need to just keep calm and understand that they're asking a question about where you produce proteins. Where do you produce proteins? That's going to be answer choice F, right? This is just cellular biochemistry. This protein is being made to be exported, so you need the rough endoplasmic reticulum. The only potential answer choices that you can even really think of are the RER or SCR, right, for making protein. And the SCR is really just for steroid synthesis. The Golgi is for distributing proteins and lipids from the ER to the membrane, but it doesn't actually make the proteins. Okay, so you're just going to pick F, and that's it. A is your mitochondria, G is the nucleus. Some people thought it would be G because they're talking about transcription factors, but the transcription factor might have come from G, but the transcription activation, the precursor protein doesn't come from the nucleus. You don't make proteins inside the nucleus. Okay, so B is your Golgi complex, C is just other shit outside, D is probably a lysosome, the green ones. Okay, so really, just stay calm. Staying calm is probably the most helpful thing you can do. 197, a normotensive 54-year-old man with normal renal function receives a heart transplant. 1 year later, he has a blood pressure that's super high and a serum creatinine concentration of 2.1. Which of the following immunosuppressive drugs is most likely to have caused these findings? So you need to find an immunosuppressive drug that causes nephrotoxicity, because his creatinine is high, blood pressure is high. And the only one here immediately should ring a bell should be cyclosporin. Cyclosporin is very nephrotoxic. In fact, I spent many days memorizing the fact that cyclosporin and tacrolimus are both nephrotoxic. Cyclosporin causes hirsutism, gingival hyperplasia, hypertension, and hyperlipidemia, which is all the stuff we're seeing in our patient. Tacrolimus causes diabetes, insulin resistance. Sirolimus was a third drug. It can also cause things. It causes pancytopenia, diabetes, and hyperlipidemia, but it's not nephrotoxic. So the lesson here was that you can give sirolimus and cyclosporin together because they don't both cause nephrotoxicity. Right? But you cannot give tacrolimus and sirolimus together because tacrolimus and sirolimus both cause diabetes. This is a topic that I spent like a couple of days really being able to describe this and memorize it, because it was pretty important. These are the first three medications in your immunosuppressants of immunology, and they're very high yield. The others are stuff you see in other places, so you learn them, and they're not that hard. And your monoclonal antibodies, again, you learn these from just experience. The more questions you do with them, and the more things you make up to try to memorize them, the better you get at it. But these first three medications are the only ones you really need to, truly memorize and master. And I did. I just spent a lot of time and I did it. Okay, so here's the memorization thing I made up, right? Spores are hairy, so imagine cyclosporin to be hairy, and remember it causes gingival hyperplasia and hirsutism. Tacrolimus doesn't cause those things, but it and sirolimus both cause diabetes. That's why they both end in limus. Just something I made, just how I think about it. So tacrolimus and sirolimus are both going to be diabetic medications. It's not good for you. Not diabetic medications that can make you diabetic. So don't combine them. Alright, so they tell you here, synergistic with cyclosporin. Sirolimus is synergistic with cyclosporin. It's an mTOR inhibitor. I got more into it because I watch a bunch of podcasts about medicine, and there's this whole concept of intermittent fasting and mTOR and whatnot, things you can do to live healthier, longer, better lives. So yeah, mTOR inhibitors are pretty key. This was easy. 73-year-old man, poor appetite, 25-pound weight loss over 4 months, otherwise asymptomatic. Lab shows normal chromic normocytic anemia. X-ray shows 2 cm perihilar mass. Biopsy shows carcinoma of the lung, small cell carcinoma of the lung. Physical exam and imaging show no clinically detectable metastases. Which of the following is the most likely explanation for the weight loss? So weight loss in this guy with malignancy is just cachexia. So the correct answer here was just to pick cytokine effect. It's definitely not weight loss because of infection. It's not weight loss because of renal failure. It's not weight loss because of suprarenal cava syndrome. Nor is it weight loss because of tumor hormone production, which really, with small cell carcinoma, it can happen. You can have tumor hormone production, but they didn't talk about any of that. Okay, cachexia is due to TNF alpha, interferon gamma, interleukin 1 and 6. Last 2 questions, also not that bad. 199 was really just a patient who took ciprofloxacin, and then she got diarrhea. That's all that happened, right? 62-year-old woman admitted to the hospital because of 3-day history of fever, chills, flank pain. On admission, she gets acute pyelonephritis diagnosis and is treated with ciprofloxacin. 3 days after, she has no more fever and chills, and her pain has decreased. 5 days after admission, she has sudden onset of watery diarrhea and lower abdominal cramps. Right, so temperature is high again, respiration is 18, blood pressure is okay. Cardiopulmonary exam shows non-abnormalities. Abdominal exam shows moderate tenderness to palpation in the lower quadrants, especially on the right. Bowel sounds are increased. Stool is brown. Test for occult blood is negative. Which of the following is the most appropriate next step? So you just do a test of the stool for C. difficile. Sketchy micro shows reaching into the stool for actually being able to find C. difficile. Right? Cipro kills the normal flora, so then C. difficile ends up thriving. That's it. 200 was a very straightforward bullshit question, but there's really not much to say for explaining it. 34-year-old man has herniated lumbar intervertebral disc. Laminectomy and removal of the herniated fragment are scheduled. Which of the following labeled sites on the normal lumbar axial CT scan shown is the most appropriate location for surgical entrance into the neural canal? And that's anterolaterally or posterolaterally, right? You know that anytime someone gets a herniation even, it actually comes out sideways, like here. These 2 areas are pretty weak. So that's the best place to go in also. That's it. Definitely not going to be A. B is another one that you might pick if you don't know much about this topic. C and E over here are just pointing at the pointy parts. Those are not going to be entrances. Those are just pointy extensions from your spine. And you don't pick those. So it was really between B or D over here. Those either this one or this one. And obviously D is the one that you pick because that's how herniations occur in the first place. Right? The posterolateral area over here, these 2 areas are pretty weak. Okay? And that's it. We're done with NBME 18. So thank you very much for joining. Keep studying. I'm going to be continuing first aid from tomorrow noon. And I also plan to make a video where I'm going to talk about the specific things I've been noticing that are very high yield in NBME and how to study better. I have a couple other topics some people emailed me to make videos about that I'm definitely going to go ahead and invest time into. And that's it. So yeah, thank you very much for joining. Thanks a lot for watching. Keep studying, and I'll see you guys again very soon.